11 months after the laminectomy, the MRI shows a well-decompressed canal and no recurrent disc, and a line of electric burning still runs from your buttock down the back of your thigh into the outside of your foot. Worse at night, unmoved by gabapentin or a higher dose, your leg is numb and it hurts at the same time. I am Dr. Padda, and I want to be precise about this. Today, spinal cord stimulation, including the evidence that never reaches the device brochures. Here is the sequence a patient in that gap actually gets, and I have watched all three branches fail the same person in the same year, re-imaged and handed back, operated on anyway, because surgery is what the building is organized to bill for, escalated on medication until you are sedated and still hurting. And when neuromodulation comes, it comes as hardware. Nobody says the sentence that explains you, the structure was corrected and the nerve was not. So what generates an electric line down your calf when there is nothing left in the canal to blame? It is a rewiring problem, not an injury. Damaged axons fire spontaneously, and that barrage drives dorsal horn neurons into a hyperexcitable state. Thresholds fall, receptive fields widen, descending inhibition loses its grip. You are left with a cord that amplifies instead of filters. Beat 2 of 4, scientific mastery, setup 2 of 2. Electrodes sit in the posterior epidural space over the dorsal columns, the highways of large A-beta fibers. Low-frequency stimulation recruits them, and the classical explanation is gate control. Note how I phrase that. The model and the dorsal horn GABA mechanisms attached to it derive largely from animal work and are incompletely confirmed in humans. 10 kilohertz and burst waveforms work below the paresthesia threshold, with no buzzing, so they are not using gate control. Their mechanisms are debated. Anyone who says otherwise is reciting marketing. Your cord also floats in cerebrospinal fluid, drifting with posture and breathing while current density falls steeply with distance. Closed-loop stimulation answers that the lead reads the evoked compound action potential and corrects each pulse. Selection is where this is abused. 4 questions come first. Is the pain neuropathic, burning, electric in a nerve's territory with sensory loss, or mechanical axial back pain, which a stimulator has no business treating? Is there a structural lesion still correctable, recurrent herniation, foraminal stenosis, pseudarthrosis, adjacent segment disease? MRI answers the first 2. Pseudarthrosis needs thin slice CT and flexion extension films because a fusion that looks solid on a plain radiograph is not always solid under load. Where imaging and symptoms disagree about which level is talking, a diagnostic selective nerve root block settles which root is generating your pain. Is it focal at all, or widespread nociplastic pain that hardware only scars? And 4th, psychological readiness. The honest version of that 4th question is softer than the field admits. Untreated depression is the one psychological variable that predicts poor long-term outcome with any consistency across the literature. Catastrophizing and active substance use have predicted outcome in some series and not others, and there is no good evidence the screening visit by itself improves anyone's result. I screen anyway, not because a questionnaire forecasts your future, but because treating a collapsed mood or an untreated substance problem beforehand is better medicine than finding it with hardware already in your back. None of those 4 questions is worth asking until the ordinary work is behind you and documented. A real course of physical therapy, appropriate medication trials, targeted diagnostic and therapeutic injections. This is not a first-line treatment and not a shortcut past one. If someone offers you an implant before that record exists, you are being sold hardware. Only then, a trial. Prone under live fluoroscopy, a 2-OHE needle enters the epidural space by interlaminar approach. Loss of resistance confirmed on imaging, not by feel. Percutaneous leads advance to the low thoracic levels, then stay externalized while you keep a log. If it does not change both your pain and your function, nothing permanent is implanted, and the leads come out at the bedside. That is not a free week, and I will not describe it as one. A trial is still an epidural procedure. Infection at the exit site, dural puncture, bleeding. It is a small, bounded, reversible risk taken deliberately instead of a large permanent one taken on faith. Mikhail and colleagues published Evoke in Lancet Neurology in 2020. Double-blind, randomized, closed loop against open loop. At 12 months, 83.1% of closed loop patients achieved at least 50% relief without increasing pain medication, against 61.0%. Funded by Saluda Medical, the manufacturer. Read that comparison for exactly what it is. 49 of 59 against 36 of 59. The raw numbers behind those percentages, and both arms had a stimulator running. Evoke tells you a device that measures the nerve's response outperforms one that only guesses at it. It does not tell you either one beats placebo because there was no placebo arm. That is a different question, and the Cochrane review is where it gets answered badly. Peterson and colleagues in JAMA Neurology in 2021 studied 10 kilohertz stimulation in diabetic neuropathy. 79% of the stimulation patients responded at 3 months against 5% on medical management alone. By 6 months, mean pain in the stimulation arm had fallen from 7.6 to 1.7 centimeters. The medical management arm went from 7.0 to 6.9. It did not move. That gap looks spectacular, and you should still discount it. The trial was open label with no sham arm, and an unblinded comparison against pills overstates what the device contributes. Funded by Nevro, the manufacturer. A 2023 Cochrane review by Traeger and colleagues. 13 trials, 699 participants with chronic low back pain, post-surgical patients included, concluded that stimulation probably does not deliver sustained benefit, outweighing its costs and risks. I do not get to skip that. The risk sheet. Infection, sometimes requiring removal of the whole system, 2% in the diabetic trial. Lead migration. Dural puncture with the positional headache that can follow for days. Epidural hematoma or direct injury to the spinal cord or a nerve root, rare. And the reason this is a genuine consent conversation and not a signature. A compressive bleed in the thoracic epidural space can leave permanent weakness or paralysis if it is not recognized and decompressed within hours. You are entitled to hear that sentence before a needle goes near your cord, not after. 31% needed revision within 2 years in one trial inside that review. Effect can fade, some elect explant, and an implant constrains future MRI. What I'm about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Someone 2 years past a lumbar decompression and fusion, leg pain electric and unbearable, nothing left to decompress by 2 surgical opinions. Examination showed a dermatomal sensory deficit with allodynia. Screening flagged collapsed sleep and demoralization, and we treated those first. The trial week is where a composite stops being tidy. Dressings, no showering, wires taped along the back, and the work of judging a treatment while wearing it. Relief was partial. Leg pain much better. The axial ache unchanged, which is the usual pattern and needs saying beforehand. Then programming visits across 2 months and a winter of physical therapy. Glycemic control and anti-inflammatory nutrition ran alongside all of it, because an exit site and a fresh implant pocket heal better in a body that is not hyperglycemic. Those measures supported the procedure. They did not replace it, and I will not sell them to you as if they had. At a year, the leg pain was manageable, and the opioid dose was lower. Not absent, not cured. That is what success looks like after a decompression that corrected the anatomy and did not repair the nerve. A leg you can stand on, not a leg you stop noticing. Some patients never reach even that, and I say so before the trial, not after. If you are in that gap, the surgery behind you, the imaging unremarkable, the leg still burning, a 4th operation will not find what is wrong, and a higher dose will only sedate you around it. What you need next is an evaluation that establishes whether your pain is genuinely neuropathic and whether a trial is reasonable for you. Learn more at painmd.tv on the Spinal Cord Stimulation page, Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5000. 5902, Monday through Friday, 8 in the morning to 5 in the afternoon. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.